There's literally nothing. There's just a jacket in there.
I mean, if there's like, I mean, you can just like hold it up. Yeah. Or like the first one.
Yeah, I'm doing the first couple.
Just say like,
where she's up there.
Oh. Like 26 people, so they were coming.
We have never RC.
Only 15. Yeah, the way I did today, like the first time I'm the one who gets it.
Can you do?
Only copy Isabel or Taylor.
Okay.
So
I mean, Jana's slides are in the beginning. Like it's just after my intro.
she's going like she's not.
I also don't know. What to say.
You don't have to say what.
For Dr. Grant, like the intro they always say.
Have they not the names?
What do you mean?
Can you ask Kagan?
She's not coming.
Can you text them? They should have somebody else. Or Daisy, is she coming?
No, Jenna texted us and said she comes.
Oh,
and asked if one of us would do the slides.
okay. I don't want to commit to it. No, I can ask Liliana.
Okay.
You can ask them.
Because I'm like on the way to pass out. So.
Pretty good.
What? Nothing. I've just been like going all day. Like I'm so done.
Okay.
Breathe there.
Whenever you say that, I should say we're on the front table up here. It works.
I mean, maybe, but. Seriously? That's fine. Really not that good. Is she on? So she's.
I'm Dr. Grant. I'm supposed to be giving the
Yes.
lecture today.
Thank
Do
you
you
so
guys
much
have
for
my
coming.
yeah? You have my slides and everything.
We do.
Okay,
I believe
perfect.
we're at
Just
it.
want to make sure. You
Yes.
guys do your club business and then.
Yes,
Sure,
it'll be
perfect.
like 20-ish minutes
20,
and
yeah.
then you'll be good to go. Thank you so much.
Yeah, you're welcome.
What?
Did you try that traditional class? Like was yours? I have one more. Is there like, I think all of them. That's what I'm gonna do. But yeah, no, I didn't know if it was all her house. I assumed it was still church. Oh, this.
Should we get started or no?
Yeah. I sure do. Yeah. Well, so you're at least this semester. Yeah. So
Hello. Okay. Hi, everyone. Welcome to the CHSS GBM for October 27th. Thank you guys so much for coming and for everyone who joined on Zoom. We will be taking attendance at the end. The QR codes are actually not on the door, but they are on the table in the front, and some of our exec members might have some, so be sure to scan that at the end. So just a reminder for anyone who may have recently joined or for our members, but in order to stay an active member, you have to make sure to attend the GBMs and stay for the entirety of our meeting, like you're doing right now. You complete service events and pay your dues. So we are still accepting dues. You can Venmo us at UNC_CHSS. It's $7 if you're a returning active member or $10 if you're a new member. So do that as soon as possible so you can get food at our GBMs and access to all the social events. So just a reminder, you have to attend 4 out of the 7 GBMs and get 2 service credit points to be an active member. And our next GBM is going to be November 10th, and that will be our last GBM of the semester. and that'll be in Manning 209, which was our last room.
Hey y'all, this is just a thank you slide for coming out to the Critter Kit event and making those for the Children's Hospital at UNC. That was a good, successful event. We made a lot of those. How do I switch to that? Okay. So we're having another blood drive on the 30th, which is a Saturday. It's going to be on South Road, I believe, the outside the Student Union. And you do have to sign up for this. And this will be a service credit if you still need those. And it does also raise money for charities. So. And then we are still recruiting for the SECU Family House meal team. If you can deliver or make meals, make sure to sign up for this. It's a great way to earn service hours and maybe service credit for the club too. So yeah, that will be on the slides too that are sent out, so y'all can sign up. And then our annual med school deans panel is coming up. That's next Friday, so put that on your calendars. Right now it's scheduled to be in the Great Hall of the Student Union, and that's at 6 p.m. next Friday. And so in the follow-up email for this meeting, we're going to send out a form that y'all can put questions in for the deans that are going to be there. You can also think of questions while at the panel, and do make sure to RSVP to this event so we know about how many people are coming.
Hey y'all, I just wanted to thank you guys again for those of you that were able to come to the Benny Capella's fundraiser a few weeks ago. We finally got in the check from the organization and we were able to raise $52.43, which is awesome. And this is going to Table, which I briefly mentioned at the last club meeting. Just another organization in the Chapel Hill community that is working at providing food security to our local children and adults. So thank you again for those of you that were able to participate with that. And then moving on to the fundraiser we had this past week, we were able to double what we raised at Benny Capella's, and we made $109.58 for Community Empowerment Fund. A little bit about this organization for those of you who have never heard of it before. They're dedicated to addressing racial wealth gaps in the Triangle area and specifically in Orange County. And then they work to help people transition out of poverty and homelessness and providing sustainable living to these families. And then they also provide numerous financial services and equitable procedures through like consulting for those families. So thank you so much for all of you who are able to come and bring your friends and roommates. We really appreciate it, and I think this will be very beneficial for this organization also. And then our big fall 2021 gala, we just wanted to keep y'all in the loop with this. This is still on November 13th. And the location is TBD, but will definitely be released within the end of this week. The proceeds will probably be going to a mental health nonprofit organization in Orange County or the Triangle area. And then the tickets will probably be between $10 and $15. And this will cover the cost of food, which sneak peek will most likely be Med Deli. And then the social evening and all of the activities planned for that night. And you will receive 1 service credit point for attending. So keep that in the back of your mind if you're still looking at getting those points by the end of the semester. And then we are hosting this alongside Public Health 360, which is another public health club. So that's it.
Hey guys, thank you for everyone who filled out the form for our Big Little program. That is up and running. So you should have gotten an email this morning or early afternoon about your pairings. So if you didn't, feel free to email us or come talk to one of the exec members after the meeting. And if you have any questions or concerns or suggestions for events or anything like that, let us know. And if you are part of the program, we'll be sending out another email soon regarding a kickoff event. So yeah, just keep an eye out for that.
All right, so we will be continuing our virtual medical shadowing program. So basically what that is healthcare professionals will present their educational background, their medical specialty, a typical week in their life, and specific cases like case studies they have seen in the past. These will be held most Tuesdays and Thursdays on Zoom from 6:30 to 7:30 p.m. We have one upcoming this Thursday that we'll talk about, but these are not for service points, which is important to keep in mind. If you do miss a session, you can make it up on Saturdays from 12 p.m. to 11:59 p.m. On our YouTube channel. And you have to complete the quiz as you do regularly by 11:59 p.m. To receive credit for shadowing.
Okay, so our upcoming shadowing sessions, there's one tomorrow with a PA, so switching it up from the physician. We have Ms. Avni Garg, and then next Tuesday, we have Dr. Michael Craig, and he's a professor of hospital medicine and a hospital medicine physician. And then next Thursday, we have Dr. Anil Gehi, a physician in cardiology. So be on the lookout for those shadowing sessions. They will all be from 6:30 to 7:30. Okay, so this is just another reminder to check your weekly email. We send out all our important updates through that. So just to ensure you never miss anything, you're up to date, you can check for those. And we'll also send a wrap-up email tomorrow morning. It'll have all the links for signups, all the information from this meeting on there. And also make sure to join our GroupMe. We have more and more people join in each week. It's just an informal way for you to ask questions and get answers quick. So if you want to join that, that'll be good. Thank you.
So if you're not part of our Heal Life page yet, make sure to join. So to do that, just log on to your Heal Life. Then you can just look up Carolina Health Samaritan Society and just click join organization and we'll add you in. And then something we do for all our events is make sure that you RSVP to them. So if you don't know how to do that, here's like a little step-by-step. So you log on to your Heal Life and then you click on the events tab on our page. And then you can click on any of the events. So on the screen, it's today's GBM. So you click on that and then it'll come up with a little RSVP. Yes, I can come or no, I can't. And then if it's something that has an in-person or virtual option, like the meeting today, then there'll probably be a question that asks if you're coming in person, just so we can decide how much food to get or snacks if we have that. And this just helps us keep track of who else coming. So make sure you do that for any of our future events.
Hey everyone. So lastly, we have our social media. We're active pretty much on Instagram, GroupMe, Facebook, Twitter, and we also have our YouTube channel where we post our virtual shadowing videos along with our GBM videos. We request all of you to follow us on social media, comment on the things we do, and also repost any posts that you think will be helpful for you and your friends. Our executive board works really hard to plan all the events that we have so far and the events that we have coming up. So if you can share them and spread the word, that'd be really nice.
And now for the speaker part of our meeting tonight is guest speaker, Dr. Shakira J. Krant, who is a hematologist oncologist who graduated in 2006 as the first medical doctor in her family, and her work focuses on care for older adults with blood diseases while also working as an assistant professor at UNC. So we could give a warm welcome to Dr. Grant.
All right, so good evening, everyone. As I was walking in here, I thought to myself, it has been about 20 years almost since I was a medical student and walked into a similar theater like this in the University of the West Indies in Trinidad, where I was trained. So it is such a privilege to be able to come today to talk about my journey as a clinician scientist and what that looks like, and to hopefully give you a little bit of a sneak peek as to what it means as you kind of move through your medical careers or as you're thinking about this from day to day. So thanks once again for this opportunity. So as mentioned before, I am an assistant professor in the Division of Hematology and Geriatric Medicine. I have a dual appointment. I'm an assistant professor. I'm on the tenure track. And that is a little bit of a distinction for people who are pursuing primarily research careers as they are climbing the so-called academic ladder. I'm a big Twitter user, so here's my Twitter handle here in case there's anything of interest that you may want to tweet about as I go through the presentation. So a little bit about me in terms of background. As mentioned, I was born and raised in Barbados. So I've included some pictures here just to show you where Barbados is. This is in the Eastern Caribbean. It's a small island of about 285,000 people. And really, I grew up in what we would consider a socially vulnerable neighborhood or community. I was the first person in my family to actually go to university and to graduate and to become a physician. And I did that at a really early age because our model is quite different from the US, where we don't actually go to college. We come straight out of what the equivalent would be high school into medical school. Some of the other things about me, so I also am an immigrant, as you can imagine, to the US. And I became in 2020 the first Black woman to graduate from a combined hematology oncology fellowship at the University of Washington in Seattle. And I identify as a woman of color in academic medicine. And these are some of the things that I follow or tag on Twitter, which is geriatric oncology, my specialty. So what is a clinician scientist? Many of you may ask. So what that means is that I am a medical doctor, so MD equivalent. And it also means that I spend the majority of my time actually doing research. And we'll talk a little bit about the types of research on a subsequent slide. But essentially, as I mentioned, I started at the University of the West Indies in Trinidad, subsequently transitioned to Barbados, which is my home country, and then ultimately came to the University of Pennsylvania, where I did my residency training, which is the step after you leave medical school. And there I then went on to do a further subspecialty in geriatric medicine. So this is what we consider a fellowship before heading out to Seattle, where I did my hematology oncology training. And so ultimately, when you put all of that together, I am left with being a geriatric hematologist oncologist. And we'll talk a little bit about what that means. So many times I'm asked, why did I decide to actually combine the specialty of geriatrics and hematology oncology together? And I say to people, why not? And really the why not behind this is really that caring for older adults is really everyone's priority. It's not only the priority of a geriatric oncologist or a geriatrician or other specialties in which you have people who have specialized in care of the older adult. The reason this becomes important is that if we look at the population as a whole, and we not only focus on North America or even in the US, we can see that the population is aging. And so what that really means is that those who are over the age of 65, they represent the fastest growing patient or population, I should say, globally. So it means that as you progress, as you think about entering medical school, taking that journey to becoming a resident, to becoming a fellow, and ultimately faculty, the patients that you are going to see, unless you are an exclusively pediatric specialty, are largely going to be older adults. So why is this important? So this is important because age is considered one of the most important risk factors for actually developing cancer. And so what this slide shows you is that as an individual gets older, the chances of them being diagnosed with a cancer also increases significantly. As we talk about older adults, and many of the times when I'm asked why geriatrics, I say because patients of the same age on the calendar, according to the year, they all age differently. So we can put two 65-year-olds in the same room, and these individuals will act differently. Their function will be different, which means that when I'm treating their cancer, that it is likely that they're not going to respond the same way, and they may encounter different challenges along the way. And so that's why it's really, really critical that when you think about caring for an older adult, that you think about how different these two individuals or multiple individuals of the same age actually are. So for me, as I've mentioned, I identify as a geriatric hematologist and oncologist. And so what that means is I went to medical school, I did a subspecialty training in internal medicine, and then that was followed by what we call a fellowship in geriatric medicine, and then ultimately fellowship training in hematology and oncology. And this is why I'm considered to be within this field. So who we are as a medical subspecialty, we provide care for older adults with cancer. And I also include hematological or blood disorders because I see primarily patients with blood disorders. And we really focus not only on what the calendar is telling us about a person's age, but really about what their function is like. And we have different ways in which we assess an individual's function. So the purpose of this talk was really to give you a little bit of introduction to me, who I am, my background, and where I am currently. And so what guides me as I do my research every single day, and I'm encountering patients, their families, and dealing with that dynamic, is this overall career mission. For me, my mission as I walk through my medical career, my medical journey, is to enhance the resiliency of older adults with cancer, and this is across the disease continuum. And what this basically means is that this is from diagnosis all the way until you are treated, and then into what we call survivorship. And what I aim to do is that I want to address the functional, cognitive, and social factors that tend to impact the outcomes of these older adults and continue to drive differences in age and race-related outcomes. So how do we do that? Or how do I do that in particular in my everyday life? So I think the first is to recognize that there are different types of research. So in terms of the model that most of you might have learned already, we really think about, are you going to be a basic scientist? Meaning, are you in the lab, not seeing patients primarily, but maybe dealing with patient samples? It could be blood, it could be looking at genetics. They're primarily basic scientists. In the middle, when we combine those two specialties between basic science and clinical, we have what is known as translational, which really means that you are taking what you learn or you develop in the lab and trying to find ways to move that into a clinical setting. And then at the other end, we have clinical. So clinical research means we're dealing with the patients, we are interfacing to figure out what is happening in real time when we develop a drug, for instance, in the translational lab. How is that patient reacting to that drug? In cancer, is it causing them to live longer? Is it shortening their life? And then when you break that down even further, you talk about the methodology behind doing clinical research. And I lump that into two broad categories. And one is quantitative, so what you can measure, and qualitative is through these discussions, interviews, focus groups that you have with patients and their care partners, for instance. And then in the middle, when you combine those two, which is what I do, you call this mixed methods type of research. So when I think about mixed methods, it's exactly as it mentions. This is a mixing of the methods, so it's a combination of either qualitative and quantitative methods, and this is usually within a single research project. And so many people may ask, why do mixed methods? So the answer is that while quantitative studies, so an example would be conducting a clinical trial, given a patient drug X, and following that patient over time to see if there is any difference in survival because of drug X. And so why survival is really a really meaningful endpoint. For some patients, especially older adults, survival is not the end game. For them, they want to know, when I take drug X, how is drug X going to affect me? Is it going to affect my quality of life? How am I getting to and from my appointments? These things are what we capture when we interview patients or interview groups of people. So we then take patients not only by seeing them for their disease, but we also consider the context in which they exist on a day-to-day basis. So this is their social environment, their cultural environment, their built environment, which would include things like access to healthcare. How do they get to and from their appointments? So all of these things are captured when we think about qualitative research. So in terms of my research, so recently my lab or my research group, I was awarded $200,000 to study the impact of multiple myeloma on older adults and their care partners. And so we are using this grant over 2 years to really dive deeper into what is happening with patients as they are newly diagnosed with a blood cancer called myeloma. We are particularly interested not only in what the disease is doing and how they're responding to treatment, but we also want to know specifically, how does their function, meaning their physical function, their social support needs, their actual cognitive or how they're thinking, and also how does their quality of life change over time, over the course of having this disease before actually seeing any form of cancer therapy until after we start treatment. How does that impact this patient's overall living? So in terms of trajectories, this is one of our studies here. And as I mentioned, we're looking at trajectories, so over time of function, quality of life, and cognitive health. Our overall objectives are that we want to quantify the frequency and severity of how cognitive and physical function are changing and by how much. We also want to examine the experiences and perspectives of patients with myeloma and their care partners. So it's really important for us to understand not only what our measurement tests are telling us, but also what patients, their care partners, or caregivers, as you may know them as, what they are also experiencing. So this is a pilot observational study. And again, as I mentioned, we are mixing those two study methods. And so this is a mixed methods study with just a small sample, about 40 patients and 15 to 20 care partners. Another one of our studies coming out of my lab, we are looking at how patients who have had a diagnosis of multiple myeloma, the blood cancer, for many years, what happens to them later in life. So again, we know that these patients are more likely to survive longer because we are improving the therapies we have available. But what is not known is, how does their quality of life and their function, how does that change over time? What are their needs? Are there other things that we may be overlooking that they may need later in their life that we don't really account for when we actually see them in our clinics? And so that is the purpose of our study. This is one of the study team members here and just our recruitment flyers for one of these studies. This was the study for those who are surviving multiple myeloma. Our group is also investigating barriers to participation in clinical trials by patients who identify primarily as Black race, and really trying to take a deeper dive as to how we can best facilitate and promote diversity among cancer clinical trial participants. So in terms of future directions for this work, so this work is essentially what we think of as addressing that overall career mission that I mentioned, which is to look at these factors as they affect individuals across the cancer care continuum, and really to provide a better understanding as to what happens from diagnosis all the way to survivorship. And then using this data to help inform what we do in the clinic and to inform the design of larger studies in which we're looking to see how myeloma therapies and the different types of myeloma therapies, how they actually influence patient-centered outcomes. And overall, we believe that these results of all of these studies will provide valuable insight as to how we can best support older adults, especially with multiple myeloma, to ensure that they have the best outcomes possible. So I think for me, as if I had to sum up my journey, as I said, I walked in and I thought about almost 20 years ago when I walked into a similar auditorium, probably as a first-year student, not dating myself, in medical school. But to now, 20 years later, to be able to stand here and to talk about the research that my lab is currently doing, I really wanted to put in here not only a focus on research. We could always talk about research and all of the work that people are doing here, but really to talk also about mentorship and sponsorship, because this is what is critical. It is at your level that people, when they come, faculty members, and you're interacting with others, you're shadowing, you are then picking up on cues on whether or not that person is a good role model. That person, unknown to them, may actually be instrumental in shaping your decision to ultimately pursue medicine, to pursue a similar specialty. And this is why I take very seriously my role as a mentor and also a sponsor for others. So this is just going to be a short focus on a mentoring program that I started since joining faculty at UNC. And just a little bit of background. For me, this is really geared towards women trainees and those who identify from Black, Indigenous, people of color groups in academic medicine, because this is the group of individuals who often suffer from a lack of mentorship, which means that they often have opportunities that they don't get compared to other groups of people. So why is this important? It's important because these things, implicit and cultural biases, structural racism, things within the institution in terms of racism, they all feed in to lead to what is known as imposter syndrome. So this feeling like you don't belong. No matter what you do, I just don't belong here. And all of these things lead to psychological distress. And ultimately what it does, it feeds into this never-ending cycle, really, where you just can't generate new research ideas. This means your productivity goes down. Grant funding, you really are not being successful with that, which is really important for people like me, where that is how we support our career, through research and grant funding. And then this leads to the inability to launch an independent research career. So thinking about all of this, when I joined faculty here in January, I really wanted to think about a way that we could proactively engage with trainees at all levels to provide them with mentorship and instruction on clinical research, methods, study design and data analysis, and scientific writing. And the whole purpose of us doing this was really to try to expand the number of students and trainees from these underrepresented ethnic and racial backgrounds who actually end up going into our building careers in clinical research. And ultimately, we really wanted to build and foster community across the wider UNC campus. So this is our current mentorship program structure. I serve as the founding director and the lead for this. These are my 3 colleagues who are also physicians. Primarily, they focus on clinical trials in the myeloma group, but they also serve as mentors. So just a little bit in terms of what this timeline looks like. So if someone is interested, they will reach out to me. We talk about what their goals are. This is meant to be a short-term program, so not over many years, but really over less than a 12-month period. Then we want to pair them according to their interests and what projects we have available, because the goal is for them to be able to have an abstract, have a manuscript, if possible, as the end result once they complete their mentored experience. So what we did is we launched this in March of 2021. And so far since March, we've had 14 trainees come through our program. Some of them are still with us, working on projects in various stages. And then we wanted to evaluate the program's effectiveness. And so we did this with a Qualtrics survey. We asked open and closed-ended questions, and we had a pretty good response rate. This is just to show the demographics of participants who responded. You can see that we had a racially diverse sample of trainees. The majority of them were MDs primarily, and you can see the mean age as noted there. So in terms of what this graph shows, this is really looking at how does the mentee perceive the mentoring relationship. And you can see that the overwhelming majority of people actually felt that the relationship was very useful to them. They felt that the mentoring person was very helpful in terms of with leadership development. And also because their focus here is on research, they were really helpful in helping them to develop their research, which is great. In terms of satisfaction, when they were asked whether or not they benefited from the mentoring relationship, they said definitely yes. In terms of overall satisfaction, this was overwhelmingly extremely helpful for them. So these are some direct participant quotes. As I mentioned, we asked open and closed-ended questions. Here you can see one of the first comments that came out was seeing someone who looks like me was really critical to that trainee. They had an opportunity to participate and explore projects that would not be normally accessible. They also learned a lot about what we were doing in our clinical space in terms of blood cancers or hematological disorders. We formed accountability. So we're not only building research skills, we're really teaching life skills that they can then take with them. In terms of participant quotes about the mentoring program, they felt like this program, and remember, this was just one person's idea within a small clinical space, that this had the potential to really make a difference in one's career. Trainees felt that they were benefiting from career advice. So again, the whole idea behind this was not only to build a mentoring program around research, but really to provide sponsorship and a connection for these trainees. So overall, this is our word cloud that we created using a summary of the frequency of all of the words that were mentioned when we asked open-ended questions about the mentoring relationship and the mentoring program. And you can see things like goals, discuss, being, intellectual, inferences, develop, up, access, helped. These are the things that really, really stood out. So what did we summarize from our program and from our experience? We felt that developing and implementing this grassroots mentoring program, this was feasible, and it was capable of attracting a diverse group of individuals. Trainees overall have high satisfaction rates with the relationship, and we're working on future work to examine how the program's effectiveness is viewed from the mentor's perspective. And we're also conducting longitudinal assessments of the trainees who are currently engaged in research. We're also tracking our metrics of research output to include publications and grants and conference presentations, which are also stemming from this work. So one of the key things that I mentioned is I mentioned what I do, but I really changed that to say what we do, because none of this work that I do would be possible without first the patients who agree to participate in our study, and then my awesome support team, which is currently expanding. I have Gianna Mills, who's a graduate research assistant in the Gillen School of Public Health, Marian Perez, who's one of our senior clinical research coordinators. And we're about to add another individual to our team. And we also have fellow physicians who work on many of these projects with us. So it really does take a team effort. And I really wanted to take some time to acknowledge all of my collaborators, my mentors. You can see that our work really spans across different disciplines, and is really critical for our success that we work together as a team. So with that, I will end, and I am happy to take any questions you have about anything I mentioned or any other questions that you may have about the field or otherwise. So thanks. Yes. Hi.
What type of questions would you ask the patients to kind of get a sense of their quality of data?
To get a sense of their quality of life?
Yeah.
Okay, so the question is, what type of questions do we ask to get a sense of a patient's quality of life? So that's a really excellent question. We actually use validated survey instruments. So questions on that would be, since start having your diagnosis of cancer, can you tell us what things have changed or what you are not able to do? So that would be an open-ended question. Other things that we ask would be, do you need help from a day-to-day basis? We also ask them to please self-rate your health. How would you view your health currently today? And we give them options of excellent, fair, poor, and good. And that actually has been found to be a good predictor of people who are going to have poor outcomes. So if you rate your health poorly, these are the patients that tend to end up in the hospital more, the people who die earlier. We also ask them things like around symptoms, so symptoms related to their cancer treatment. And we add all of these things together on these validated scales. One of them is the EORTC, Quality of Life Questionnaire. And we get a score, and that score tells us what the patient's overall quality of life rating is. Great. Yes.
So I know you mentioned like end of life care, but my question is like, what is UNC doing in terms of like palliative care, and especially like what advances have been made in like recent years?
Yeah. So the question is about what is UNC doing in terms of palliative care and what advances have been made in end of life care. So one of the things I would say for me as a geriatrician, we are trained in palliative medicine. However, palliative medicine is a separate specialty, but we all have to think about it and integrate it into cancer care. One of the biggest advances is the recognition that early palliative care, especially in those who have advanced cancers, actually is associated with improved quality of life. And when they looked at this among patients with lung cancer, it actually was associated with improved survival. So there is an increasing recognition that having cancer in particular, there is a role for individuals to receive palliative care along with chemotherapy at the same time to ensure that we are addressing all of their symptoms. And symptoms could be toxicities related to their treatment, addressing end-of-life issues such as thinking about living wills, who's going to be my healthcare proxy and decision-making. There's a lot of movements within the healthcare system, especially for us to make sure we're documenting conversations about advanced care planning. And what that means is when a patient has a cancer diagnosis, we get this pop-up in our electronic medical record that asks us, did we address advanced care planning? What is this patient's DNR, do not resuscitate status? Are they a full code, as you will get accustomed to that term, or not? So I would say overall, the field of palliative medicine has made tremendous advances at UNC, just like every other health system. They're really pushing clinicians, oncologists, hematologists to have these conversations early, make early referrals to palliative care to make sure that we are constantly addressing the symptoms and all the other issues that we may not necessarily think of as we're focused on their cancer. Yes. Yes. So you're asking what type of blood diseases do I treat? Oh, yep. So I only treat blood cancer called multiple myeloma. But hematologists generally in an academic institution like this, within our division, we are divided into those who see malignant or cancer of the blood and those who actually see non-malignant diseases or benign. In terms of where autoimmune disorders involving the blood would fall, they would fall to our non-malignant colleagues. Again, because of this being an academic institution, we actually see only one cancer type. I know it seems like I should have all the time in the world, but what that means is we are considered the experts within that particular cancer, at least within this institution, and probably regionally and nationally. So multiple myeloma is just one of the blood cancers. We have people who focus on lymphoma, leukemia, which is another blood cancer, and also something called myelodysplastic syndromes, another type, but each of us will only see that particular cancer type. Yeah.
As a clinical researcher, do you still think you're able to develop good personal relationships with patients?
Yeah. Yeah, so that is a great question. So the question is whether or not I can develop good relationships with my patients. And I will say that is the basis of what I do. So because I do qualitative research, a lot of that, our time is spent really interviewing patients. As a matter of fact, before I came here, we were just on an 1.5-hour interview where we are conducting focus groups with patients who are Black, to understand what are the challenges that they face when trying to make a decision about participating in a clinical trial. And so a lot of what I do, even in my clinical space and my research space, it all overlaps. And so I've developed quite a good relationship, probably more so than sometimes I should, but in terms of just being available for my patients, being attuned to their needs. And I think that comes from doing qualitative work, listening to the patients and what they want, what are the things that are important to them, and I then translate that into my clinical practice in real time. So as an example, I'll give you is in our study that is ongoing, we were talking about what type of interactions with providers patients value most. The things that we have been hearing recurring is that they value feeling as if they have a provider they can trust. They want to know that there's somebody on the other end who doesn't just see them as another number to check their box in a busy clinic. They want to know that we care. I heard it up to this afternoon in my research. And the key thing that was said to me by one of the participants was, I want to know when I come into your office, take time to ask me, how am I doing? Is there anything happening in my life? Don't just jump right into, this is my cancer, these are my labs. So these are even lessons for you as you walk through your careers. Don't just see that patient as just another to-do on your checklist. Don't just spend all the time in the electronic medical record. These patients really value when you have that face-to-face interaction and when you really just see them as just another human being. So I think that that is really critical. And I would say for me, that is at the core of what I do. Mhm. Yeah. Mhm. Yeah, so the question is, how would I compare the MBBS system to the US? So I would say, in terms of coming here, what that meant, MBBS, for those of you not familiar, is Bachelor of Medicine, Bachelor of Surgery. This is built on the European model, which is everywhere else except the US. I believe Australia also, you get an MBBS. The training is very rigorous, I will say. I still remember the days of doing 36-hour calls every 3 days, and that was in person with no duty hour rules and all these things. So you do get quite a robust clinical experience. Making the transition here to do my residency honestly did not feel difficult because I had already been practicing there and had already been through baptism by fire, as I like to call it. So the transition here did not feel as difficult when I compare the system. In terms of differences across, system practicing in a small country, we are limited by resources. We have socialist medicine, which is different from the US. So definitely here you have many more resources available to offer patients, things like clinical trials and more robust research. And I would say that that was probably the biggest differences. And then the protection that they offer with duty hours and not needing to work 36 hours for call every 3 days. So a much lighter workload, I would say. Yeah.
So you were talking about like basic research and then translating that into clinical practices. And given that the kind of work you do has a lot of regulations and it's within the framework of an institute, is it challenging sometimes while doing that translation? Does it take longer than how you expect it to be or how you hope it would be?
Yeah, so in terms of the translational element, so I actually am not a translational researcher, but I would say from my colleagues, because in myeloma, we tend to collaborate with them a lot. There is a big lag time between when you develop something in the lab and you test it in an animal, for instance, and you want to translate that into the human. That process is very long. So in terms of what those people do, they can spend many, many years just trying to develop one area of their research and then trying to eventually bring that to the patient because patient safety is always a priority. For me, in terms of what I'm working on the clinical facing end, so I'm already seeing them many years after they've gone through the entire drug development process, and they're already well established into giving a particular drug. And then I'm seeing them now to understand how this drug, how this disease, how that is overall affecting their lives. So a little bit of a difference in terms of the spectrum, but translational work tends to be a little bit longer, especially, and also basic science too, but definitely rewarding because on my end, I need basic scientists and I need translational scientists in order to do the work that I do. So, yeah. All right. Any other questions? No? Go. Yep. Yeah, so the profession question, and I think I was supposed to talk about this a little bit, so thank you for bringing that up. So I think for me, it was a little bit different because I always knew from a really young age that I wanted to be in medicine. I remember making this bold declaration that I was not only going to be a doctor, which sounded really absurd based on my background where I grew up, but I actually wanted to be an oncologist. And so that was always my guiding light. And that was really shaped early based on my own personal experience, seeing family members suffer through cancer and what it was doing to our family and friends. And then ultimately the decision to combine oncology with geriatrics came during my residency while I was at the University of Pennsylvania. And it was then that I was constantly seeing patients who were older, and the same questions kept coming up. How do we treat them? Where do we treat them? Are we even going to treat them? And so I really felt as if at that point, I needed to get a better understanding as to how we make treatment decisions for older adults, how we adjust or adopt our therapies based on their age, their function. And it was during my geriatrics rotation while at the University of Pennsylvania that I knew that I needed to combine my geriatrics training with hematology oncology. So that was always at my core to be an oncologist. And then ultimately in residency was really this focus that developed after seeing that older adults were really this complicated population that we really didn't know how or when or why. So that's how I thought about it. Mhm. Any other questions? No? All right. Well, thank you once again. This was really great, and certainly wish all of you all the best as you advance through your medical careers. So thanks.
Thank you so much, Dr. Grant, for coming out and speaking to us. That was an incredible presentation. Thank you everyone for coming to our meeting. In order to get attendance credit, make sure to scan the QR codes at the front. And we should have coffee and candy. I'm not sure if they brought it back yet, but that will be on your way out. So thank you guys for coming out.
And then I couldn't find that one. I thought it was like.